Nurse Practitioner Lloyd
Tapper.
Tapper. And he is very knowledgeable, not just nurse, but nurse practitioner, which is equal to MD. He has a PhD degree, and he's got so much experience. And I've been doing chiropractic for a while, but I've been looking for a practitioner that I can work with to help out with joint healing and joint regeneration. And I found a guy. So most people don't quite understand what stem cell PRP prolotherapy is. So the best way to introduce that is giving some good insight from his knowledge and experience. So Lloyd's going to give you some great information. And at the end, if you have any questions or concerns, he's a Google right here. He's an encyclopedia right here.
And I have no plans for the evening.
So I think we're in for a great treat. So we're very excited to share this knowledge. So I just want to introduce to Lloyd and give him a big warm welcome.
That's what brings me here with you guys tonight, this afternoon, to talk a little bit about regenerative medicine. So specifically, we're going to talk about something called platelet-rich plasma. We're also going to talk about stem cell therapy and where the evidence is and what's happening both in the clinical environment as well as politically with stem cells. This presentation that you're looking at tonight is going to go over what arthritis is. We're going to look at how it affects your joints in particular and what the implications are. We're going to look at research-based treatments. So what does the evidence say about what works for arthritis and what doesn't? And we're going to discuss the regenerative medicine options, specifically around platelet-rich plasma and around stem cell. There is a third option. It's called prolotherapy. And it uses a combination of dextrose and lidocaine, and we can talk about that as well. And then we're going to discuss who is the ideal candidate for platelet-rich plasma treatment, and then a little bit around stem cell. And we'll talk about experiences with this treatment as well. And arthritis itself is a progressive, painful condition. In this particular case, it causes a complete degeneration of the joint. So arthritis, you may know or have been told that it affects the cartilage of the joint. But to be honest, it affects the entire joint, not just the cartilage. Over time, it involves a breakdown of the entire joint. And once it starts, it's usually a progressive type of presentation. So it results in profound cartilage loss. It also can result in bone loss, the development of bone spurs, as well as weakening of the tissues around that joint. The joint itself, and this area here would be a meniscus. These are the tendons. Patella here, or your kneecap as you would know it, and synovial fluid in the middle. So you can see here, this is what we call the articulating surface of the joint. It's how our joint moves, and you can see that right there. So when you get arthritis, you start having a breakdown of this particular cartilage. We're going to show you what that looks like in just a minute. As the arthritis progresses, you're going to see that this area becomes much thinner. And then as it continues to progress, you'll see that the cartilage itself starts to completely degenerate, and you have bone that comes through that cartilage, and that's called bone spurs. And you can see how it grows up through the cartilage as the entire joint starts to degenerate. And here they are here. So as this progresses, this is how your provider, your care provider, your surgeon, your family doctor, all of those people, this is how they make a decision as to how bad your arthritis is and whether or not you can go without a joint replacement or whether or not you should have a joint replacement.
Okay.
But we do know that there are risk factors. We know that injuries to a joint in the past can potentially increase your chances of arthritis. We also know that particular procedures, like previous scopes of your knee, can increase the chances of getting arthritis within about 5 to 7 years of having that scope. Okay? There seems to be a bit of a family history associated with arthritis as well, and a previous traumatic injury to a joint makes a difference. For people that are dealing with a lot of weight on their knees, they are more prone to having arthritis as well. So right now, up to 80% of people over the age of 65 will have some type of arthritis, some stage of arthritis that's diagnosed on X-ray. It affects women more than it does men. 18% of women, 15% of men. And right now it's affecting about 4.6 million Canadians at this point in time. That number is going to go up because we know the incidence and prevalence increases with age. And our population is aging. Women more than men over 65, history of injury, family history, and a high body mass index is really our risk factors at this point in time. So we have two focuses on treatment options. We have the prevention treatment option, and then we have the treatment option for when or if you're diagnosed with arthritis. So our first option, when it comes to prevention, is exercise. And so, of course, with exercise, moderate physical activity, you can reduce your risk of arthritis as well as maintaining a good body weight at that point in time. Maintaining your body weight is the second evidence-based approach to prevention, as well as rehabilitation, whether that be chiropractic or physiotherapy or massage. All of those things we know as an ability to help reduce your risk for developing arthritis. When you are diagnosed with arthritis, there are a few other things that you can do in order to help treat. So first, of course, is again your rehab. At this point in time, we have a variety of medications that we're going to talk about. We have injection therapies that we're going to talk about, as well as offloading devices that we call them. You guys probably know them as braces for your joint. And then, of course, joint amputation and replacement is the other option that we have. So let's talk about those in detail and what we consider in looking at treatment options. The first one is Tylenol. Many of you, it's called acetaminophen. That's one of our first line treatments, but we know that once you get to moderate to severe symptoms, Tylenol within the evidence is not known to be great for the management of pain associated with arthritis. In early stages of arthritis, quite often it can be effective, but throughout the progression, it becomes less effective. And that's the challenges here. Of course, upset stomach is another potential issue associated with the use of Tylenol. Inflammatories, these are our NSAIDs. So they are the second step in the treatment of pain associated with arthritis. And they do work. They work, they're evidence-based for mild to moderate and sometimes in severe arthritis. But here's the challenges. We know that arthritis affects mostly people over the age of 65. What comes with over the age of 65? Sometimes high blood pressure, sometimes heart issues, sometimes stomach issues, and sometimes kidney issues. And anti-inflammatories in this particular population is what we call contraindicated. So it's things that we suggest that people stay away from. For example, if you have high blood pressure, taking Advil or naproxen or Aleve, all of those things can increase your blood pressure. We also know that high blood pressure can lead to kidney disease. So when you take Advil and you put more pressure on your kidneys, which is where it's clear, it can lead you to more kidney problems. We also know that if you have stomach ulcers or any issues with your stomach, non-steroidal anti-inflammatories can be really hard and they can cause bleeding from your stomach. So NSAIDs, or non-steroidal anti-inflammatories, are great. The challenge is that people over the age of 65 can have a lot of contraindications, and so therefore they can't use them. And anybody who's had heart disease should not be using non-steroidal anti-inflammatories. So other options here are opiates. These are the Tylenol number 3s, the Percocets, the fentanyls, all of the things that now, of course, we know in the media are leading to significant addiction. And so in general, within the healthcare community, there is a consensus that we should really, really be getting away from prescribing narcotics for the management of pain, with the exception of cancer pain. Meaning that anytime we are prescribing them, we're thinking about the implications for that person we're prescribing for. Because we know that the majority of people who go on to get addicted to narcotics have their first prescription from a care provider. So when you're sitting down in front of your primary care provider, when that's a physician, if that's a physician or a family all ages nurse practitioner, and they're looking at how to manage your pain, this is what they're thinking about. And if they decide to, what is your chances that their prescription is going to cause you more problems in the future? So we all struggle with that, because none of us want to see our patients in pain, but we also don't want to contribute to this. The other one is steroid injections. Now, steroid injections have long been considered the standard of treatment for people with moderate to severe arthritis in their joint. And it does work. It does work. But more and more we're getting additional information that says that it could potentially increase how fast steroids cause breakdown of the cartilage. There's been a couple of good studies now that suggest multiple injections with steroid can increase how quickly the arthritis progresses. So that's a challenge. The other challenge is that in typical cases, your first steroid injection may last you up to a year. Your second one often lasts you about 6 months. Your third one can last you maybe 3 months, and in general, your fourth one may not work at all. So our bodies get sensitized to it. We're really not sure why that happens, and the timelines I'm giving you are pretty much a stereotypical timeline. There are exceptions, but that's typically the trend that we see. The more you use, the less effective they are. So that's a challenge done in Boston by a gentleman, a physician, who has a long history in the management of arthritis. And so he did a study of steroid injections that was posted in JAMA, which is the Journal of American Medicine Association. This is a very reputable journal. And what he did was, he did an MRI of everyone's knee, and then he injected them with steroid. And he did this, I think, correct me, I think it was 3 times in a year, and then did post-MRI. And what he found was, when he compared both knees, the rate of cartilage loss was higher in the group that had the steroid injection. You know about hyaluronic acid? Anybody else? The majority of people know hyaluronic acid because it's what we put in people's faces to get volume in cosmetics. Well, there's a kind for knees as well. It's a little thicker. And there's multiple names. There's Monovis, there's Duralane, there's Symvis, many different options. But they all typically do the same thing. It's a lubrication for your joint. So it's a very thick, clear gel that's injected into the joint, and that fluid, hyaluronic acid, lubricates the joint. And if it's going to work for you, it's going to work well. And if it's not going to work for you, it pretty much doesn't work at all. And as clinicians, our challenge is to try and figure out who it's going to work for, and we're not very good at it. We don't know who this is going to work for. And so we educate, or certainly I'll speak for myself here, I educate my clients that this is available real solution. If it's going to work for you, the maximum time that you're going to get out of it is about 6 to 8 months in general, because it breaks down. Your body absorbs it with time. So for people that it works well, and they get about 6 to 8 months, and then they have to have it repeat on a regular. The final option here in this particular area is the surgical option. And this, of course, can be in most cases, this is a removal of your joint. joint amputation, top and bottom. They replace the joint. On the top and bottom, you'll have an entirely new joint. Up to 20% of people will have ongoing knee pain, even after they've had the surgery. We know that 2% will have a significant event during surgery, and that event can be either mild or catastrophic, which can include death, pulmonary embolus, which is a blood clot in your lung, etc. And not everyone is a surgical candidate, so that's important. We have a lot of people that are later in life, they're in chronic pain with arthritis, but they have other health issues, which makes them not an ideal surgical candidate, and so they don't move forward with surgery. And not everyone qualifies, and of course, the wait time can be significant. And so, based on all of that, this is what we know. Tylenol doesn't work for everybody. You can take anti-inflammatories. A lot of people choose not to, and a lot of people can't. Steroid injections don't always work, and if you use them, they have a decreasing rate of return. Not everybody is a surgical candidate, and the wait times can be long. That's where we are. That, for me, is where regenerative medicine comes in, which is what we're going to talk about now. So regenerative medicine, what is it? It is a branch of medicine that involves technologies designed to help your body heal itself. That's the definition of regenerative medicine. There's actually platelet-rich plasma. We're going to talk about stem cell. The third one is called Prolotherapy, and we can certainly talk about that as well today. Let's get started with PRP. Who's heard of it? So in general, we do a blood draw from your arm. Comes out of your arm the same as if you go to a lab. Then we take that blood and we spin it in a centrifuge right in the office, right where you are. In general, it spins for about 10 minutes. And then we only take the yellow. Everything red we throw away, goes straight to the garbage. We only take the yellow, which is the platelets, and we inject that back into the site of injury or irritation. So when we're talking about arthritis and joints today, I do this work for people who have tendon tears, ligament tears, rotator cuff, hamstrings, all of those things. We use PRP for that as well. So it's been around since the 80s, and of course was made famous by a lot of elite athletes, ball players, golfers. You've probably heard of all of them. And now it's been, of course, identified as safe, and the latest evidence suggests that it should be one of the #1 treatments associated with the treatment of mild to moderate arthritis. Unfortunately, I don't believe we're there in the health community yet. I don't think a lot of people are familiar or aware of PRP, and many of our providers are still in the steroid world, but there's more and more growing evidence that PRP should actually be one of the first treatments in the early identification of joint arthritis. Proven safe and effective. So this is where we are. We take the platelets, and this is what your tube will look like. The red blood cells are at the bottom. All of the yellow is PRP, and we inject that into the joint. When you inject it, the platelets break down, they disintegrate, and they release human growth factor. And we all have growth factor in our body. Anytime we injure it, our body has its own growth factors. It rushes to the site and tries to heal. When you don't heal, that's when we take the PRP and we inject concentrated platelets, which break down and give you a boost in your growth factors. And that's what causes the healing. And in the presence of arthritis is what causes the pain management. You start seeing improvement in moderate to severe arthritis. You won't see improvement for about 6 to 12 weeks. And that's because your body is attempting to heal as much as it can, keeping in mind there is no cure for osteoarthritis. This is about pain management and function here. So in-office procedure, clients can expect to be sore for about 1 to 3 days. Your joint is going to be sore after this is injected, because in essence what we're telling your body is that you have a brand new injury. You have a brand new injury. You just injured yourself, and your body now needs to heal that. During this point in time, The discussion around non-steroidal anti-inflammatories, the research is mixed. The majority of people will tell you that if you get PRP, you cannot take anti-inflammatories for pain. There's a couple of studies out of the US by orthopedic surgeons, mostly around shoulders, that are showing that when you actually use non-steroidal anti-inflammatories with PRP, you actually get a better outcome. The challenge is that there's only 2 studies in the world like this, and so at this point in time, I suggest that people don't use anti-inflammatories with PRP, but that may change in the future. Okay? And up here, you will need to see physio in 5 to 7 days. You, sir, mentioned to me earlier, do you have an age range for this? When it comes to who I do physio PRP on, one of my biggest indicators as to whether or not I'll move forward or not is whether or not somebody is willing to do the rehab right here, physio or chiro. If someone comes to me and says, Lloyd, I want you to inject my knee, but I'm not going to chiro, I'm not going to physio, I'm not doing the rehab, my response will be very respectful. But I will say to them, if this is not part of your treatment plan, you're not going to be happy with the treatment I'm providing. Because if you remember, osteoarthritis is a deconditioning of the entire joint. So I can manage your pain and might get you better function, but if you don't do the physio and the chiro and the rehab, that joint is not going to get stronger, and you're not going to be happy. So I actually put that in my consent. When you consent to treatment, you are consenting to doing the rehabilitation associated with the outcome. And when I get someone call me back 6 weeks to 2 months and say, Lloyd, your treatment did work, the first thing I will say is, who is your rehab team? I need to talk to them. And quite often the response I will get is, I don't have some. And so that's part of my discussion.
In the special scenario with most of you, and when Lloyd said physio, what do you mean by rehabilitation? Physio doesn't necessarily mean physiotherapist. It could be athletic therapist, massage therapist, chiropractic. Practitioner as a team that allows your joints and your structure to be sound. The interesting thing about all of you, you're already getting rehabilitation.
That's exactly
You're already
right.
getting that therapy, and you're not at base level, you're here already.
The benefit of me talking to you guys today is I'm not worried that you're not going to do the rehab. You're already in that mind frame. You're already in that space. You're already looking at your next step in order to help get you more active with less discomfort. I'm seeing someone who's coming directly from a self-referral, and I do take self-referrals. This is more important to me. I dig into the background a little bit more to see if there is a history of chiropractic care, rehab efforts, and all of those things. But certainly not worried about that here today. Here's where we go. PRP works faster in combination with viscosupplementation. This is the important part. Remember we talked about monovis and synvis, all this gel? Well, people come to me all the time and say, can I have the PRP with the gel? That must be better. And there's 4 studies that I know of, there may be more. There's 4 studies that say when you combine monovis with the viscosupplementation with the PRP, your outcome will occur faster by about 3 to 4 weeks. So instead of waiting 6 to 8 weeks for your outcome, you will get a faster outcome by about 3 to 4 weeks. The issue is, it's not going to last longer. In general, PRP lasts for 1 year. Monovis, synvis, Durolane lasts for about 6 months. So if you spend the $350 or $400 for the synvis, or the monovis, or the Durolane, you're going to get a faster outcome, but it's not going to last longer than if you just use PRP alone. It goes like this. Lloyd, I want to be in Palm Springs within a month, and I want to do 9 to 18 holes. How do I get there? My response is, use monovis with PRP. That's going to be your fastest response. Someone else comes in later in the day and says, Lloyd, it's COVID, I'm going nowhere, but I don't want to be in pain. What do? just PRP. Because if you still want a faster outcome, you can get it by adding the monovis, but you weigh the cost of $400 for the monovis versus what you're going to get from it. And really, it's an improvement in discomfort. That's if you've had a prior steroid injection, this could be the most important part of the presentation. If you've had a prior steroid injection, you have to wait a minimum of 6 weeks for PRP, because the steroid will kill the PRP. Dead. It won't work. If you have steroid injections to the point where they don't work anymore, neither will PRP, because the steroid kills something called alpha granules. And it's the alpha granules that allow us to improve and to heal. So once the steroid has killed the alpha granules, there is very, very little success with PRP. Very, very little. So for those that choose to exhaust the steroid first, hoping to move to PRP, it is not going to work for you. Give me back my life. Huge. Works well. Miracle. Fixed my joint. Everything is wonderful. Everything is lovely. Just go do it. That's what you see in the papers and in the tablets. This is what you see in the medical journals. Health Canada investigates Canadian stem cell clinics. This is true. There was 5 in the country. Don't quote me on the timelines, but I know they've all been shut down. And that was about, I'm going to say about 2.5 years ago. And they received letters from Health Canada saying you have a certain period of time. We have a lot of people interested in stem cell. And there's been a lot of hype in the media around stem cell. But the evidence that we have to support stem cell is very, very, very weak at this point in time. The only true Health Canada approved indication for stem cell is in cancer, things like leukemia. But it is not approved in any way for orthopedic injuries, including arthritis. So I'm going to go through with you what the procedures involve so that you know a little bit about it, and then we'll talk about a few other things. So there's 2 approaches to stem cell treatments. One is where you actually take fat out of your abdomen, you spin that fat, you take out the stem cells, and then you process them and inject them back into the site of injury or irritation. And the other one is the bone marrow option. That's where we put freezing into the back of your hip, and we go into the hip with a needle, and then we pull out the blood with stem cells in it, and we process that and put it back in. That's the procedures for stem cell. Keeping in mind that this is not done by me, for sure, and not done in Canada at this point in time for the purposes of orthopedic treatments. So here's where we are. Stem cell is not available in Canada at this point in time. There is a significant lack of research. Safety regulations are a concern. And a report in 2017 that was a combination of the recommendations from the Alberta Bone and Joint Network, as well as, I do believe, Alberta Health Services, was that treatment should not be provided in private or public settings at this point in time. Now, during these recommendations, there was talk of doing additional research, collaborating with orthopedic surgeons and other professionals in order to get research up and running to really find out, is there any true validity and does stem cell work? To my knowledge at this point in time, I don't know of any active studies. That doesn't mean they're not happening. I suspect they are happening. I'm just not familiar with them. We know that current treatments for people with OA are not effective for everybody. Platelet-rich plasma is safe and effective, and it is evidence-based. We know that combining the viscosupplementation with PRP works a little faster, but does not last longer. We know that PRP can last you up to 12 to 16 months and can be repeated at any point in time. I want to talk about this a little bit more. If I get somebody who's coming in who's waiting for surgery and they want PRP, they're not going to get one PRP treatment with a full result. They are not. Their best treatment option would be one PRP times 3, each of 6-week intervals. And because they're waiting for a joint amputation, they're not going to get the full outcome. They're not going to be pain-free, but they will do well. And many of them are very happy that it's allowed them to bridge themselves to surgery with a reduction in pain and an improvement in mobility. PRP is ideally positioned for people with mild to moderate arthritis. And so in my position, one of the biggest challenges is trying to get people to come in for early treatment and not, I'm on the OR surgical wait list and I need you to do PRP for me. The faster I can get you and treat you, the better outcome you're going to have around pain management and function. So Health Canada has not approved stem cell, and research regarding the effectiveness of stem cell needs to be expanded rapidly, and Alberta position statement, we went through that. I use platelet-rich plasma therapy, and I use Prolotherapy. Here's the difference. Platelet-rich plasma is your own blood. Prolotherapy is nothing more than highly, highly concentrated sugar. It is 50% dextrose, and it's included with a numbing agent called lidocaine. It has been around since 1937, and it came from a plastic surgeon who injured his thumb. And for some unknown and ungodly reason, he decided it was a good idea to inject his thumb with sugar. And it worked. And so from that period of time, people have been exploring prolotherapy, the injection of dextrose and lidocaine into tendons and ligaments that are not healing. So the only indication for prolotherapy in my hands is for people that have an injury that hasn't healed. Just your body tried to heal it, it's greater than 3 months later, it's not healed. So now you need to tell your body to go and heal something that it hasn't healed before. So in these cases, we use high-dose dextrose and lidocaine, and we inject it at the site of injury or irritation. And that creates swelling and inflammation. And that swelling and inflammation tells your body, oops, you just injured yourself. You just fell down a flight of stairs, or you just twisted your ankle, or you just done this or that. And it goes in and tries to heal it again. So in prolotherapy, we do a set of injections every 3 weeks. So every 3 weeks, we are initiating an inflammatory response. My big question is, I have an injury, are you going to choose PRP for me, or are you going to choose prolotherapy? When I look at the evidence, and in my hands, I get better outcomes with prolotherapy in spinal problems. So people who've been T-boned in car accidents that had a rib dislocate, and now they need that tendon, ligament healed to keep that rib in place. People who have been rear-ended in a motor vehicle accident and have neck pain that need to have that pain managed and those tendons tightly. That's prolotherapy for me. I also use prolotherapy in some forms of lower back arthritis. Not all. And the arthritis that I choose to treat with prolotherapy is usually from vasectomy pain. My word, what coincidence.
That's why it's there for you.
The facet joints are here. It's where the two bones move over each other or articulate. When you use ultrasound to inject between these bones, you start tightening up the ligaments and reducing the amount of pain over time by initiating an inflammatory response. And this is anecdotal, no research on this, full disclaimer. When I'm treating somebody with vasectomy lower back arthritis with no disc issues, I can typically get about a 60% improvement and no more. That, you might say, is not a lot. But for someone who was dependent on opiates for pain, where we're taking anti-inflammatories and having huge side effects associated with that. A reduction of 60%. I mean, this is not a cure, but a reduction in pain of 60% for lower back arthritis is substantial for them. It's the difference between them and game. So, to answer the question, prolotherapy is only for chronic injuries, whereas PRP can be used for brand new ones or old ones. Prolotherapy is dextrose and lidocaine. It is not like a product. The treatment schedule is different, and for me, I typically use prolotherapy more in spinal issues as opposed to in peripheral joint issues. There are some exceptions to that. High ankle sprains, I may choose prolotherapy. Tennis elbow, the research between PRP and prolotherapy is pretty head-to-head. But if I can get a tennis elbow fixed with one PRP, one visit, and it's going to take me 4 to 6 visits in prolotherapy and ongoing discomfort, I'm going to choose PRP for that person as opposed to prolotherapy. So if somebody's coming to me for prolotherapy, I'm in my head, I'm thinking I'm treating a C-spine, high neck issue, whiplash, or an upper thoracic issue. I'm treating somebody who's had a dislocated rib. I'm treating someone with what we call hypermobility of the bones. So it means that the bones in the spine are moving a little bit too much and it's generating pain. Or I'm treating lower lumbar facetogenic arthritis. And the final one is, well, not the final one. The other one is spondylolisthesis. So that's when the bones in your spine actually slide over each other too much. The biggest one of all that I treat with Prolo is SI joint. And most of the SI joint, so the SI joint is right here, ladies and gentlemen. So it's where your hip bone joins onto your tailbone, in essence, right there. It's excruciating pain, you'll know it if you have it. And you get it in people who've been rear-ended with their foot on the bike. And if your leg just shears straight back and pulls those ligaments, we use it a lot for that. In pregnant women, after they've given birth, and their pelvis doesn't tighten up, we use it a lot now as well.
Prolotherapy is more for instability.
Yeah.
You know, things don't stick. It starts to kind of
glue.
Yeah, and if you have a lot of instability, prolotherapy is like a glue, like a crazy glue, to make sure that it stays in place. But most of the people have too much fixation or too much restriction. So people who have too much restriction, you do prolotherapy, it's counterproductive.
Yes.
So that's where Lloyd's education, knowledge, and our skills combine together to make sure.
Maybe with joint arthritis, I can do an assessment, I can do an ultrasound, say you have arthritis or PRP. If you go home and call your friend and say, hey, this guy's got your cure for whiplash, and that person comes into me, there's a good chance I'm going to do an assessment and send it out to my clinic. And the reason is because I want his or any physio, chiropractor, anybody who specializes in this area, the reason I'm referring you is I want the benefit of those hands. I want to know how much movement there is and whether or not there's enough movement for me to treat. And the value of having that particular assessment is simply this: specialist, chiro, physio, whomever, who can tell you, Lloyd, this shouldn't be moving that much. There's too much give, there's too much play, it's generating pain. That's how I can be certain to move forward with the program.
So we're very fortunate to work with all of you, actually, more teams coming. And I feel like I'm kind of like collecting talents. I like to collect talent and collect great people to work together. So Nurse Practitioner Lloyd's going to be working with us once a week to have an opportunity to get a consult with Lloyd. And that consult involves me putting input along with all the other therapists who's done some treatment to help you get you from here to here. Now, his treatment does not replace what we do. It just compounds it. It just makes it better.